Welcome, everyone. I am Gio, your host for the Ask an ECV Expert series of talks. I am here today with Stefan Bilodeau. We will be covering how COVID impacts vulnerable populations and nursing homes. We'll start a bit with Stefan's work, then go on into a prepared Q&A with a PowerPoint as we are time limited today. If we have time, a quick live Q&A will follow or be mixed in as we can. Now, Stefan, tell us about your work.
Okay, so I've prepared a couple slides just for you to have a better understanding of what was done. So it's really, as you said, related to nursing homes. It's a mix of meta-analysis and data analytics on the nursing homes. And I've just highlighted the fact that the reported data on that sector is not so well reported in many countries. So that was a challenge. So typically in data analytics, we're dealing with too much data. In this very item, for this very item, it was the opposite. So data were rare and not regular, and that was a big challenge. You just explained that we will start with some slides, so I will not go that way, but I want to make a first disclaimer for those who are listening. So I'm an engineer by trade, a data scientist for the last 20 plus years, lecturer and university entrepreneur, but I'm not a physician, a nurse, any medical background. So, but for some courses at Johns Hopkins Public Health School in basic epidemiology, and with a nice, I call that a nice certification in contact tracing. So I can call you to ask if you have been in contact with people, but I'm not a doctor. So the other thing I wanted to highlight is the fact that all the analysis which is done is essentially based on comparison between data. And there are a lot of differences and many differences in the different jurisdictions, states, countries, regions, provinces in Canada from where I am. So just in the definition of what is a nursing home or what is a long-term care center, and not only that, it's the way they're reporting the cases and the deaths. So sometimes it's just the suspected that are confirmed, but sometimes they're including suspected, so as for many other things. So even with all that in mind, personally, I think that the comparison is always giving us a perspective that we don't have before adding them. So that's why we started with others a couple of months ago, already working on nursing homes. And I was just explaining it to Shakuntala just before we started today. The onset of the issue on the nursing home side came really early in our province in Canada. So I'm from Quebec, not so far from Montreal, and there, early March, there were already a lot of institutions where outbreaks were seen. Even if the first thing in Canada were on the West Coast, it spread pretty quickly. And what was seen at the time is up to 300 institutions in long-term care and nursing homes were affected with outbreaks. It's a big number, but not that much compared to the total number. So there is something like 2,500 institutions like that in my province. So 300, it's not a big portion of it. But within these 300 institutions, in a matter of 2 months and a half, we reached something like more than 3,000 deaths. So that was quite huge. And that started the evaluation that we've made on the analysis slide. What I wanted to highlight is just one of the points which was a bit more severe is in only one of those 300, 101 deaths were seen amongst 192 residents. So that's something like 53% of people died. 100% were infected by COVID. That's a tragedy in itself. So that pushed us to look further into the data. And as you might see here, it quickly, I have released at some point on ECV some information like that we published regarding this. And we clearly see that on this chart, the CHSLD is the definition of nursing home. It's fully public nursing home. here you have private elderly homes and the like. So about 1,900 of the deaths were directly in public homes, 500 were in private. We see different things in other jurisdictions, by the way. So and I will talk about it later. So it really depends on how they're taking it care of and what's the regulation around things. And you've seen, and we've seen many things, and that's just for you to understand the story. So we quickly went to other countries. At the time, personally, I was looking at Sweden because of their big exposure related to their herd immunity, let's say, fiction. So that's my take on that. So I was analyzing that, and analyzing the herd immunity things. Quickly, we went to the long-term care homes as well. So it's in Swedish, but the purple section is all the deaths in Sweden, and the blue one, or the green blue one, is just for the long-term care. So you see that even in Sweden, something like close to half of the deaths are directly in long-term care. And I'm not talking about just person with 70 years old and more, but really those who are in that kind of settings. Same thing in Canada. So we have a lot of deaths in nursing homes, but not that much in residence. I just showed this the preceding slides. At home, 300 out of 3,000, so it's even 10%. While they're representing the biggest chunk of elders in our country. Same thing in Sweden. The big majority of elders and seniors are not in nursing homes or long-term care, but still that represents the biggest portion of that. So I'm not talking too much about the hammer and dents compared to the herd immunity things. We're probably all on the same page on that. And we quickly got to other countries which had faced huge outbreaks. Belgium is one, same kind of numbers. And we were surprised after the first and the second country, but then it multiplied. So Belgium seemed the same. So I've translated a couple of things because they're all in French here. But you see, Maison de Repos is nursing homes, 50% of the deaths were in Belgium. That's the full country here. So we're in these settings. Somewhere in mid-May, they've decided to add the suspected case, and then this 50% started from June, somewhere around June. They started to add this directly, and it's becoming 64%. So in fact, it's a bit like what we see in Canada. 64% of the deaths are in nursing homes. They've also realized, and you see that on the left, that asymptomatic represent a significant portion of the people which were infected in homes, care homes and nursing home settings. So that was a big thing as well. So typically up to maybe early May, asymptomatic were kind of neglected in the equation. For nursing homes, that's a big portion of the numbers. You see that here. So asymptomatic in nursing homes in Belgium, if you're going to the older portion of the population, it's really a high number. That's 60 and that's 80. So we're talking about 60 something of asymptomatic infection. Same thing in England. England and UK, in fact, England and Wales were the most affected. Same kind of numbers there as well. I'll not look at the numbers with you, but you see the same thing. That's the weeks, 16 weeks from one being January 1st up to almost now. These numbers went crazy at some point as well in England. But I will talk about some lessons learned, and England was a good model in catching up on that front. So I will talk about that later. So we compared a lot of those jurisdictions I was just mentioning and showing, from Quebec, indeed, Belgium, to some states as well, including Pennsylvania, Massachusetts, Connecticut, Arizona, which is hidden behind Texas, and it has now surpassed Texas. By the way, Arizona is the most, the states which is growing the most in terms of the deaths in the care homes and the long-term care as well. And New Jersey, indeed, which was at the beginning, one of the worst, but not more right now. So in terms of percentage of deaths to the total deaths in the area. So there were some reports of that in the New York Times more recently, so end of June and a bit earlier. So those numbers, we were following them since the end of May. The CMS released their first data publicly on that, so I think the week of the 24th of May. So that was a bit late compared to other countries, but still that was absolutely significant, and we saw the same kind of pattern as well. That's the kind of things we've seen. So we've seen, depending on which states you have worst case and better cases, and typically the case fatality rate overall is about 17%, but you have states where it's 60 something and more. So that's a huge percentage of it. So very similar to the worst case in Canada and the worst case in the UK and in Belgium, as I've said earlier. So overall, the last official data from the CMS were saying that there is 35,000, more than 35,500 deaths already in the residents in the nursing homes, in fact. So that's already huge in the US, and it's really not finished. So if I look at the numbers right now, it's still growing and it will continue to grow. That's the cases by state. So you see right now where the cases are the worst in the US in terms of number of cases from the beginning. So indeed, New York has the worst in terms of number from the beginning, but right now it's a slower pace. So it passed the peak essentially. Many other states, it's not the case. For example, Arizona, which I was talking about, or Texas or Florida right now, all these states are still growing at a fast pace. That's the kind of comparison you can do between all these states. So you have, in terms of per resident, so it's not the absolute value here, it's the proportion on the residents. So you see per 1,000 residents what it is. So New Jersey is really the worst. So Massachusetts, Connecticut, Rhode Island are all in the same range of 300 out of 1,000. So it's about a third, almost a third of the residents. And then you pass the second, I would say, the second batch of states, which are more in the 20% or something like that. So this is Maryland, Louisiana, Arizona now. Arizona was at 10% just 2-3 weeks ago, and now it's already in the close to 20. So it's growing fast. And you have others than Illinois, etc. So that was the case. If we look at the deaths, it's similar, but not exactly. So you're seeing the deaths are worse in some states nearby New York. So you see not really good results in New Jersey, in Connecticut, as I've mentioned, in Pennsylvania as well. While they're not the biggest in terms of number of cases, in terms of number of deaths, they're really high in numbers. So you have the same kind of per capita numbers here, and still New Jersey is the worst right now. Massachusetts and Connecticut not very, very far, but it's getting lower pretty soon after that. And when I'm saying lower, it's not really low. Take into account that 50 on this chart means that for every 1,000 residents, 50 have died. That's a huge and severe conditions, severe outcome. So the fact is, we can compare that in many ways. I don't want to go into the details of that today. I wanted to let some room for the discussions, and I'm writing quickly to the Q&A, by the way. So then we compared not only states between themselves, so we compared many jurisdictions from region and countries, so substantial numbers in terms of population in nursing homes, for example, but still many jurisdictions. So from Australia, British Columbia, Israel, up to Arizona, Texas, England, and at the end of this table. And we just kind of rank them in terms of the number of deaths per million population, and we did the same in terms of deaths in nursing homes per million population, just to have comparable data to compare. So Belgium was the worst in terms of the number of deaths per in the nursing homes, always per million. But then quickly we have Massachusetts, Connecticut, Quebec, my province, New Jersey, and Spain, and England, Pennsylvania, which are really high in these numbers. So, and that allowed us to start to compare what were the conditions in those states that made it so severe. So we have many countries where it was really going well. So I might outline Australia, Slovenia, South Korea, Germany, which are really good in terms of the nursing home outcomes. And then we were able to split best case versus the worst case versus the best cases. So and from that, we start to compare what they were using in terms of regulation, if they had some staffing problem, if they have some, and we started to highlight some trends. And that's where we are right now. It's a work in progress, and still many things to evaluate. But I think we are starting to get a pretty a clearer picture that it's not by accident that those jurisdictions went better or worse. So there are conditions in place. Some of these conditions are kind of accelerating the outcomes towards good or worst, in fact. So that was my pre-presentations.
Yeah, thank you. There's a lot of data in there. Will we be able to have this slide set available as a link?
Yeah, I can share that after the presentation.
Okay, thank you. Awesome. So question that kind of rolls right off of what you were saying about having some burgeoning understanding of what works and what doesn't. Have we seen any nursing homes where not only has COVID been it's a little bit more the disease arrived in the nursing home, and were we able to stop the spread within the nursing home and eliminate it? Have we seen that, or is it usually once it gets in, there's not much that can be done?
That was not necessarily done quickly as a flip of a coin, or that was taking time anyways. But there are success stories on that front. So areas where they were contaminated, one of which I think of is, and that's why it's here, it's Vancouver, BC. So Vancouver was the first city in Canada which had outbreaks of the COVID, and indirectly in some nursing homes. I think they had something like 7 or 8 nursing homes at the beginning, really quickly, because they were not aware, like many states in the U.S., like New York, essentially. But in Vancouver, it was directly in the nursing homes. But very quickly, as mentioned at the bottom of the slide, the government decided to change the way it would be operated. They got it really well from the start. And they controlled a bit better how the healthcare worker would be used in these facilities. So they would not allow people to work across facilities, as you see here. It made a huge difference. And then as of June 5, they only have something like 160 cases in the whole provinces, not only in nursing homes. So starting from maybe 30, 40 cases in March, they kept it really low, and it was continuously reducing. So as I said, it's not a pure success because they still have some, but they really controlled the outbreaks. So they're controlling really well. And it's by doing some different things and some important things related to, in their case, it was related to visitors and the staff. So you have the numbers, but I don't want to go that far. Just go ahead.
Yeah, the staff, having the staff only work at one place really helps because it isolates, and so you don't get one person becoming a super spreader event at multiple nursing homes. So that is like the mechanism of how this regulation works is very clear. and obvious there. So yeah, that is a definitely good piece of solution making.
Exactly, and it proved to be it's what happened. So we have the results showing that, contrary to other jurisdictions, we didn't took this approach. Belgium in Europe is a good example of that. They absolutely allow people to work within many facilities. That was a way to manage the team. And you're right, this single thing it's one of the biggest impact for sure.
So what are some things that can be done when there is a local outbreak that hasn't gotten into a care facility yet, to protect the people and the workers of a care facility?
That's another example of success, which is in fact San Francisco. Um, this facility, it's the Jewish Living, the Center for Jewish Living in San Francisco, which has it's a campus with many, and they've decided to, in fact, also rather than being the state or the province like in BC, it was the facility itself, the management of the facility, which better controlled how they would be using their own staff. They would be supplying them with proper numbers of protective equipment from the start. You might recall that it looks like fine right now in July, but in March it was stressing everybody. PPE were the discussion of the day almost everywhere. But they started really early to do the things correctly. How they did, it's still unclear how they were able to get protective equipment while others were not, but they did. So that's part on their side. That's part of how they control things. And then isolating correctly the residents, and they kept the infection rate really low from the start. So that's another of the big secrets here. That was kept really low. They were lucky for some point because in the area in San Francisco, you've not seen outbreaks as high as in other states, for example, in other area in the states, in California, but in other states in general as well. But still, it doesn't take much to get, I've shown in the preceding slide, one single nursing home with 192 persons, residents, and had 101 deaths. So it doesn't take thousands of nursing homes to be a catastrophe. So what they did is great. So that's another example of success.
So it's kind of each and every nursing home is its own situation, and each one really matters, because each one is a complete catastrophe when it gets infected.
Yes, it's a mix of, I would say, government help and regulations, as well as the management within these facilities, whether it's a campus like in San Francisco, whether it's a single facility, single building. The local team needs to organize itself, and with the help of proper regulation or proper context, they're able to manage it. So it's a mix of the two, I would say. But definitely the local team is important for sure.
And sort of the having the logistics in place, I would imagine, is part of it, being able to run this with more safety and security, making sure that there are as few ways for COVID to get into the facility as possible. And all of that sort of takes the ability to do it is as important as the will and the vision to do it. So these kind of institutions may need local support in order to operate safely, because many of them are kind of run on shoestring budgets.
Absolutely. So it's why I said the government support, government being local government or state or federal government, but at least one of the government should help. On the resource side, you're right. It can be funding, but it can also be other resources. I was talking about PPE. So that can be another type of resource, but definitely they need it because, as you said, so they're really running with short. They're just ends meet is a struggling every month, and it was the case. By the way, one of the problem nursing homes are facing almost everywhere in the world is is before the COVID situation, they were already struggling. They were lacking of staff and workers and caregivers. Uh, they were having troubles getting properly funded. Regulation was unclear. It's not only in the US or in Canada that regulation is different between states and federal, or province and federal. So in many countries, we see that. Some countries are not like this, but a lot of countries in the western side of the globe is that's typical of many countries, and that causes problems in this semi-health system environment, because we're not really in a hospital setting. We're not in a really as structured as what you see in hospitals. It's typically a mix of public and private, and the regulation is not even for depending on what's the exact kind of services they're giving. So that's another issue. So that's why it's important that the local communities could be involved, as well as the government, federal, state, or even city or local governments.
Yeah. So we hear a lot about nursing homes, but not too much about other high-risk institutions. Could you tell us some other institutions which we should pay attention to and try and fortify, or encourage to fortify, or build local awareness of?
Definitely. So I will switch a couple slides before, because I had other examples to show, but I can come back to that. Australia is a good one, by the way, in general, because they were acting fast. But on the Germany, same thing. So for the that's the, I think I switched too far into the okay, I will get it. So there are other types indeed of institutions that needs to be looked at a bit further. For example, and it was in Buffalo News a month ago, essentially. So disabled person or group homes are another type, another settings, which is close, in fact, to the care homes and the retired homes, but for another type of vulnerable residents. So this is an example of that, and in this case, the COVID just in the state of New York has already killed hundreds of persons in group homes, essentially in the developmentally ill or disabled persons. Prison is another example. Prison, because they're confined, you're facing congregated persons, incarcerated, in fact, people. They are vulnerable, but at the same time, they're not as vulnerable as older persons. Yeah, and you see that in numbers. So, for example, in the US, you have a couple million, 2.3 million people in prison. Right now, there are just, I should not say just, but if we compare that to nursing homes with 35,000 persons which have died, with the same order of magnitude of institution, 600 in prison. So this is important because each lives matter, how every lives matter, but the fact is, in numbers, it's much smaller. So, and I think since it's a much more regulated environment, prisons much more regulated than nursing homes, there are possibilities to, I would say, organize it a bit better according to the COVID conditions. What's missing still in the prison, it's in the organizations. For what I've seen so far, they would need help in knowing what has to be done, but they're already quite good at separating physically persons, so that part is well done. They're not that vulnerable in terms of health, so they don't have health status. I'm talking about the residents, or in fact the incarcerated people here. So vulnerability in terms of health is a bit less, but still they're congregated and aggregated in small environments, so they need to be taken into account a bit more. The fact that we have a virus that can be transmitted by asymptomatic. So, and it's now still, it's the workers, or whether it's the guards or whether it's the other staff which is coming into prison, which are the risk for the prisoners, in fact. So that needs to be a bit better control. But in numbers, it's not showing that much right now. So, but there is a risk for sure. And the other type, which is a bit more at risk from my standpoint, it's the veteran homes and veteran um, hospitals or care center, a bit like for the same reason as nursing homes, essentially. So then you might often have people with health status which are making them a bit more vulnerable. At the same time, there are in numbers. So typically, you're talking about 200, 300, even more persons in the same campus or in the same area. So that's a place that should be looked at. And there are successes. The one I'm showing right now, which was published in the LA Times, it is a success because that was managed by a surgeon in California, which made the difference there. The kind of things he made should be reproduced elsewhere as well. So that's another type of at-risk or high-risk institution that should be taken care of a bit more right now.
Yeah, it seems a lot of this is like developmentally disabled people aren't going to be able to social distance very effectively. People in prison aren't allowed to social distance very effectively
Right.
because of the flow. And that shows the importance of social distancing.
Absolutely.
So there have been a number of stories of circulating around where, uh, so I guess a follow-up question that we have in the chat here is, could any type of communal residence be considered a high-risk institution, e.g., university boarding rooms, dorm rooms, and similar?
Indeed, they are for different reasons, but a bit like, in fact, a bar is a risk institution now, you know. So we've seen that in many, but the dormitory room and cafeteria and all this, that kind of setting is already something which is at risk. So those institutions which are coming with that, and it's even worse for shelter or rehab institution and stuff like that, which are where people are not necessarily they're not incarcerated, but they would be there for weeks or months, depending. So as soon as you multiply the number of days, the number of potential contact, and the number of person in a room, it's already a high risk situation. So, and then it needs for the management of these institutions at least to organize their operation to avoid making those clientele in more at risk than what they are. And still we're coming back to the same issue with the workers. It's not their fault. They're coming into the community, they're living there, they have family, and then the next day they're coming back into this, whether it's for cleaning the dormitory room or whether it's for taking care in a rehab institution. So they're coming back, and if this community is not under control in terms of the outbreak, then they're becoming the vectors for this smaller outbreak in this facility to start. So they need to put in place some restrictions or conditions or things to do anyway, even if it's not as, if the clientele is not as vulnerable as in a nursing home, they are still. And it's coming to another point I've highlighted in the last few days. Even regular schools might become high-risk institution in a short time period. I don't know if you want me to emphasize a bit on that, but the fact is, in some jurisdictions right now, we see a high increase in infection rate in young persons. So I'm talking about 0 to 18 years old. So, and there were articles coming out from Florida in the last few days saying that, but it's not the first jurisdiction which have seen that. In Canada, we've seen a multiplication by 3 of the infection rate among the young persons in the last few weeks. And we see that also in some jurisdiction in Europe. So I don't know what's happening right now, but the data tells us right now that there is an onset of something regarding the young persons right now. And we all know that these young persons in September or so will come back into big aggregated and big facilities. Not that big, but the classroom is still 15, 20, 30% if there is no limitation. So it's already another situation at risk that might come soon. And the numbers this summer are not really good in that front. So far, that's still numbers. These numbers are still to be evaluated more because it's just starting. Why it starts 2-3 months after the first onset of that in Europe and North America, and why it has not been seen so far in Asia, which started 6 months ago, I don't know. But definitely the numbers are there, and typically they don't lie. So that's what we're seeing.
Yeah, there's a whole talk on schools and green zones and risk management and safety for our children.
Absolutely.
And the speculation there is not something we really need to get into, but it's very concerning to hear that the spreading rate is skyrocketing in young people. That's very concerning to hear. And so another question that I think is a very important one to kind of go into while we still have some time left is there have been several stories circulating around saying that in New York City, people infected with COVID were sent back to nursing homes, and this caused like much of the catastrophe in New York City. Is this true? What really happened? And how should we be thinking about that? Because from what I looked into it, it was a little bit more complicated than portrayed on the internet, on chat forums, or on the late night news of sort of political slants. But it wasn't easy to really clarify what was going on. So I'd love your thoughts on that, Stefan.
Yes, that's true that New York, and you see that on the right side. The Department of Health in New York asked for readmission of COVID-19 patient into nursing homes 2 months ago. And I gave the number in this. So there were something like 6,000 persons which came back to nursing homes. But New York, contrary to other things, so that's the first portion of what is typically said. It's true. So New York asked for that for 2-3 months, but it's one of the states which has not that much deaths into the nursing homes compared to others. In New York State, it's like 1/6. It's still significant. It's still bad, but 1/6, if you compare that to the neighboring states, New Jersey, Connecticut, and the other states around, it's like 3 to 4 times smaller. Okay, so that's not the cause of the death in New York City. So that is clear. Definitely, it had an impact, indeed, but it was a choice, for what I understand, between overcrowding the hospitals while the nursing homes had some safe spot, I would say, and it was done with some restrictions and regulation. So these restrictions and regulation, they've been put in place at the proper time, at the beginning. So they limited the impact of it, a bit like as I was mentioning the case in Vancouver. So they had outbreaks in nursing homes. They were not governmentally regulated as in New York, but they controlled it. So New York did a bit what Vancouver did and BC did. So they controlled the outbreak as soon as they were knowing that it was inside the home, the nursing home. Contrary to the bad example in Montreal I was talking about. So this nursing home, which had 101 deaths out of 192, the main problem is that the authorities were even not aware these people were infected. So then it spread to the full population. So yes, so the answer is mixed. Yes, that's what New York did, but they did it with at some conditions. It was a choice. If it's a good one or a bad one, overall, I cannot say. For the nursing home, definitely not the best case, the best thing to do. But for the overall health system, that's another thing. So that I cannot say. I cannot tell.
Sort of my takeaway when I looked into this was that they were moving infected nursing home patients to nursing homes that were more infected, and uninfected nursing home patients to uh, nursing homes without outbreaks, and trying to manage the situation. That was my takeaway. And it seemed, given the constraint of resources, it seemed like a not crazy idea, whereas the way that it was depicted was as completely crazy, just like shoving infected people in with everybody else. And that is not, as far as I can tell, what happened.
And that was at
And
a
you seem
time
to,
where, oh, sorry, Joe.
yeah, and you seem to be saying roughly the same thing, that it may not have been the ideal way to address the situation, but it wasn't catastrophic the way that it has been portrayed.
Definitely not. The numbers are not telling that. And as I said, that was at a time where New York City and the hospitals in the area were missing ventilators and basic things. So that was a big struggle in the hospitals. And as it's written there, it was recovering coronavirus patients that were sent in homes, nursing homes that were already equipped and already having COVID-19 cases. So you're right. So that's why I said that was done with some conditions and an organization which made it controllable.
All right, thanks. That's really important to clear up. One of our people who works in the elder care industry asks, generally, do you think nursing home workers are being called as essential workers or as healthcare workers? And what would that kind of difference in definition of status mean in the broader context of keeping people safe?
Considering the situation, they should be considered essential workers, and at the same time, they're health workers. So they are definitely at the front of this pandemic in the most vulnerable settings. So they definitely deserve to get better conditions first. Conditions is a wide term, so I'm talking certainly about compensations, which is probably too small in many countries and states. And not only compensations, but equipment. So PPE for caregivers were not treated as PPE for hospital workers, which are important definitely. But as the pandemic was developing, we just realized that the deaths and the worst of the outcomes were in these settings. So definitely workers in general need more helps, more considerations, more compensations, and have regulations that help them. I was talking about the fact that when you have some conditions where workers do not have to switch between one facility and another. So sometimes it's not possible because of their working conditions. So if working conditions are adapted for them to be able not to be working in two different facilities with two different bosses sometimes, the worst case is, and we've seen that in data in the study that we've looked at in England, UK. So they've seen that for the workers which are working for staff agencies, that was where the outbreaks were the worst. So the nursing homes and the long-term care, which were using staff agencies to fill their staff requirements, that's where I repeat it because it's important, that's where UK saw, and in fact England, which was the worst part of UK in terms of the deaths, saw the most death, and it was absolutely significant on the statistics side, so on the data side. So, and it's because of two things. Not only they were changing from one facility to another, but also these employees were changing from one culture, organizational culture, to another. So they're working in one facility where the rules are this and that, and they're then the next day working into another facility where they don't have established the same rules. So, and you know, for health workers, it's always good to have the same pattern, the same things that you're doing every day, because you will drop something if it's changing from day to day with one way to do things, one way to put and take your mask out, one way to put your gowns. It's always different from one setting to another. So that's why the worst case were not necessarily for those people which were changing facilities to one facility to another facility in the same organization. The worst cases were when they were changing from one client or one boss to another one because it was another culture, as I said. So that was where the data were showing the worst outbreaks in infections and in deaths at the same time. But for workers to be able to choose, they need support, as I said, a better compensation, but also regulation that force the management of the facility to treat them proper way. So that's the point.
Right. Let's say someone in a nursing home tests positive. What steps should the nursing home take to get the best outcome in that situation?
Um, we're working, as you know, on new guidelines. ECV should release new guidelines, and that's exactly one of the point in the guidelines. So I don't want to read everything, but definitely there are two subset of the question. So if it's just one case which is contaminated, then the simple thing to do is isolating this case, making sure it's not in contact with anyone else. But for the caregivers, and even the caregivers, you don't switch every 2 hours. You make sure that there's some control on that. But that's the simple case. But typically what you see is more than one case at a time. It's really rare that you have just one case. It happens, but it's not that much. So then you're cohorting the symptomatic. So then you need to have a hot zone and a cold zone, and you need to reorganize the facility itself. So if you have more than one, definitely that's a bigger job. So there are many things to do, but cohorting is the first thing to do. And then you have different things related to PPE, to making sure that the staff working with this hot zone is different than the one in the cold zone. TCD, we're calling that green zone and red zone at the state level, but it could be the same wording at the facility level. And then there are many others, and that should be released in the coming days. So that will be public as well.
That's good to hear. We're still working on these problems and trying to get this best solutions out to people who need them. What about pooled PCR testing to help with the turnover of that? Would that be a useful addition?
Pool testing for nursing homes, it's yes, but it depends. I know it's not a good answer to any question. It depends because of different things. I don't want you to read everything, but it's good for one reason, and it's the one I've already shown earlier. Asymptomatic is a difficult thing to manage in a nursing home, and pool testing is really good at getting asymptomatic in the population. So for that reason, pool testing is relevant for nursing homes. How it can be implemented, that's a bit more difficult, but it's already happening in a couple of countries. Germany is doing it, South Korea is doing it, and Australia partially, but there are jurisdictions which are able, countries and states, sorry, in the provinces in these, so which are doing it. So it's feasible, and it's, as I said, really good at taking care of asymptomatic and small outbreaks, because the weakness of pool testing is when you're in a situation where everybody is infected. Not everybody, but a big portion. For example, I was talking about schools earlier. In Florida, 31% of 0 to 18 years old person are infected according to the test they're doing right now. And it's not a 200-person test, it's 54,000 person tested, out of which 16,000 are infected. So in those conditions with really high percent of infection rate, pool testing is getting a bit less interesting. So for example, in States right now, Arizona would not be a good place to do pool testing in nursing homes because of the high percentage. My hometown, not exactly my hometown, but my closest big town, Montreal, is not a good place to do that as well because of the high level of people in nursing homes which have been contaminated.
So,
So that's yes, but it depends. Okay.
all right. Speaking of this, knock right off or jump right off from it is, what does the asymptomatic cases look like in nursing homes? Is it the elderly? Is it the young people who work there? Is it a combination of both? Can you overview that real quickly?
The two. So effectively, the biggest portion, the infection typically in the nursing home is coming from outside. So it's coming essentially from visitors, workers. So that's the first portion of asymptomatic, which are important. But it's also amongst the residents. So, but it's a kind of second wave then. So if we cut it from the start, that's the best thing to do. But as soon as it's not done, then pool testing amongst residents is relevant as well, because asymptomatic amongst residents we're seeing a lot, and Belgium did a great study on that. So and it's proven with substantial numbers. So that's not accidental numbers. That's really proven numbers.
Do we have any knowledge on whether these are asymptomatic or pre-symptomatic? In other words, are they going through the entire life cycle of the disease without symptoms, or is it just that they haven't gotten to symptoms yet when we realize that they're sick?
The study is too, you see that on the left side. It's a study which was released on July 1st. So right now, this is, they have not disclosed how many persons out of these cases which had passed all the steps. You know, essentially, even for some population, the number of days where the people stays with the disease is increasing. We're talking about it's like a more and more normal. We hear about people being sick for 60 days now. So it's a bit difficult right now because we don't have, we need to step back a bit and get more data to respond correctly to your question. But definitely, I would say in Belgium, it's a mix of the two. The proportion is not there yet.
All right. Speaking of the people bringing the disease into these institutions as being a major risk vector, are there any success stories of high-risk institutions housing their workers in some safe place where the probability of infection is low? Sort of what we've seen with some factory workers who will work a 30-day shift in order to stay safe.
I've looked a bit more at the nursing homes and care home settings, and we've seen many in that. There were successes all around the world. In France, I've talked about Australia earlier. It's not there, but in Newark, Ohio, in Georgia, same thing. So it's not an easy thing to do because those workers were also isolated for weeks, if not months. But when they've done it, as the cases that I'm showing, the success was clear. So
Yeah.
the rate of infection was really, really low. All those cases have no death, although those not cases, all those situations have a really small number of cases, but no death at all. So that's all good. That's the ultimate way to manage it. So for some special situation with really vulnerable person, and where the staff is open to do that, that's really a good thing to do. But it's not easy because staff,
Yeah.
workers, caregivers have family, and that's something that might be different. That's a case by case thing, I would say.
It's definitely something that's heroic. Whenever I've seen this in the news, like factory workers do 30-day shift to make mask supplies so that they can get it out, I'm just like, that's heroic. And then you look at this 65 days of isolation, that's heroic. Like respect, like mad respect.
Absolutely. They're heroes for sure. Absolutely. They were at the front for all the time and for a long period of time, separated from families, communities, whatever. That's indeed, it had a really huge impact on the situation of their own residents, and but they've sacrificed their life for weeks and months, as you said. Absolutely.
Yeah, and one of our persons who works in the elder care field has said that a worker might do 6 to 7 days of 8 to 12 hour shifts per week. Just like it's really heroic what some of these workers are doing to try
Absolutely.
and keep the facilities running and to keep their people safe. So it's like I have a lot of respect for what some of these people are doing to run their facilities,
Absolutely.
even though
That's why I
it's
saey're at
been
the
kind of
same
a
time essential worker and health workers for me. So they're at the front of this war on the planet. They deserve more considerations than what we see in many places right now. So that I'm absolutely sure of that.
yeah. All right, we are closing in on time. We have 2 to 3 minutes left if there are any final questions. Otherwise, we can wrap up. Do we have any? Anyone, if you want to jump on audio, you're welcome to.
So we do have a few questions in the chat, but luckily we have amazing Stefan who offered to keep answering questions for us after this meeting is done. So
In the channel, yeah?
yes, we're going to use the ECV com channel, which I can share again in general, to ask more questions if your question didn't get answered today, and Stefan has offered to try to answer those to the best that he can in that text setting. So Stefan, thank you so much for your time and for all of these amazing resources that you've shared with us. Gio, thank you so much for helping that conversation stay alive and well. And everyone, thanks so much for coming. You have 2 minutes until our daily call. And so please, please join us again next week.